It's Mari McInerney from Croaky here at the Advanced Pharmacy Australia Conference in Adelaide, and I'm here with one of the workshop conversations presenters and organisers. Benita, could you introduce yourself, please?
Yeah, I'm Benita Suckling. I'm the Assistant Director of Pharmacy and Community and Oral Health in Metro North in Brisbane, and my background for the last several years has been working in opioid stewardship and medication safety, and part of that role has kind of led me to reading a lot of coroners cases over the course of my practice to find kind of learnings both as an individual clinician and for the organisation and other clinicians to take from them, and that's kind of what's brought me to this conversation session here today.
And you actually have started a podcast about that. Can you talk about what it is and what prompted you to do that?
Yeah, so over the course of my practice and reading those coroners cases, I was noticing that they come in the format of being text documents that are kind of 20 to 40 pages, very detailed, really riveting for me to read, but not super accessible for other clinicians who have busy lives and are balancing lots of demands about CPD and work and home life. But the things that I was taking from those cases, what I was learning, and the stories were so impactful for me as an individual clinician in influencing how I practiced, and in kind of carrying the weight of those stories and of those patients that had the awful outcomes in the reviews that I was doing, both of patients clinically on the ward when I was working in that capacity, and then of doing incident reviews in a medication safety capacity. And I really wanted other clinicians to have better access and more easy access to these lessons that we've learned in the hardest way possible. That someone has had the tragic outcome of passing away in a healthcare setting.
And interestingly, you said you sort of delayed doing it, not expecting you'd get approval for it.
Yeah.
Because it is hard to get information out of bureaucracies, etc. now.
Yeah.
But you had a good
run.
Yeah.
I had a good run. So I was, the idea for this had been in my head for quite a few years, thinking that I was a avid consumer of podcasts and audiobooks, and that was something that was really accessible on my commute to work, was when I mainly listened to that kind of content, and that those coroners cases, because what you're doing is reading, normally is just reading those long documents, that I would happily listen to someone else read them to me on my commute so that I could still get the learnings and the information about it without having to sit down, with a big wad of paper and a highlighter to figure it out. But I did think, given the content is, quite emotive, potentially quite sensitive, talking about deaths in a healthcare setting, I thought that might be something that was a little bit too curly to float in the workplace, but I was very well supported when I did finally decide to take the leap and put the idea out there, because sometimes we don't want to share our ideas because we don't want them to be dashed, and so putting it out there, I was so fortunate that my boss was supportive and thought it was a good idea. I reached out to the Queensland or the Brisbane coroner's office, and Ainsley Kierkegaard is the Brisbane coroner, was so supportive and encouraging and has contributed to the podcast herself as well. And then having the support of the organisation that I work for as well, from kind of a legal and comms perspective, to be able to really bring it to life and to share it with our community within our healthcare setting, and then for me to be able to share it a bit more broadly as well.
And can you say how you select the cases that you look at? What are you looking to get across?
From a pharmacist perspective, most of the ones that I'm familiar with and conscious of have been medication-related incidents and in a hospital setting. So, so far we've got kind of one case series that's released, and we are hoping to be able to release the recording of the one that we discussed today here at conference. So they're two key ones that I've encountered in my practice and have used over and over in education in my workplace, and really wanted to be able to share it with more people, which podcasting enables you to do, to share it a lot more widely. So that's kind of been the initial piece. Has been looking at kind of medication safety incidents with that kind of pharmacist and multidisciplinary lens, because that's what I'm familiar with. But I suppose there's no reason that we couldn't extend to kind of other healthcare types of investigations. So really being able to draw out those elements, because any of these incidents, it's not one simple thing that happened or went wrong. There's always a suite of things that we can learn from them, and depending on the type of clinician, maybe the specialty we're working in, and our level of experience, or where we are in the organisation, if we have kind of influence to change systems, what we take from those cases when we listen to it as an early career clinician or much further along is going to be different. So it just wanted those cases to be something that has something for everyone, I guess, in it.
I take your point that there are multiple factors involved, but one of the first things you looked at today here was bias.
Yes.
That plays a big role, does it?
Yeah. Well, I think that the way that I was introducing kind of bias into the discussion about incident review was that when we are reviewing an incident, we bring the kind of colour and the lens of our own experience. So the kind of bias like, hindsight bias is a big one as well, that we're looking at the case after it's all happened. So looking back, we can see it with total clarity, but that wasn't the experience of the people moving through that incident that it was happening to. They didn't have all of the information they needed at the time like we do looking back on it. So there's kind of that element of bias, and bringing that bias to a review means that we're not learning everything that we can from it. And that goes for kind of other types of bias as well. So like fundamental attribution error, where we're just blaming another person or a particular characteristic or personality trait about them. It's like, well, that would happen to them, because they don't pay much attention. That doesn't kind of give credence to all the many other things that happened in the situation to mean that person was in that situation at that time. Other things like kind of anchoring bias, where we think what happened and we only focus on kind of looking down that pathway of the incident and miss potentially other root causes or other learning opportunities from it. So kind of starting from the point, and that's what we did in the session today, was looking at it from a point of like, what do we think, what do we assume, and let's just leave that at the door and try and come at it with an open mind to think about it. To take as much from it as we possibly can to learn, rather than to focus on what we think we already know and just keep reinforcing that.
And are there systemic factors that allow us to learn from coronial processes?
Yeah, it's an interesting question, because I think that piece of kind of making the story available is kind of one very important way that we can learn from it. So it's great that in Queensland, because the legislation might vary a little bit from state to state, that there's that real death prevention core of the legislation that means that these get published and these get shared, and that some even non-inquest findings do get shared as well. So there's that piece, is that the coroner does make those things public. And then to a degree, it's kind of we take from it then what we will. So those individual institutions that are involved in an incident might have a bit more impetus to implement particular changes on coronial recommendations, but for everyone else, we need to translate that into our own practice, into our own workplace, because we all do work in complex and different systems with different patient cohorts, different cultures. So I think it's very much on either not necessarily individual clinicians, but on the culture in your workplace of sharing the story, so that we can share that load of taking the learnings that we can and making sure that it never happens again in a workplace like our own.
And is that a deficit, that there is not a systemic approach in that way? And I'm not suggesting I would know how to do it, but I know from a lot of First Nations deaths in custody, in health settings in custody too, there's that problem that it never changes fundamentally practice sort of across the nation. Do you see it as a deficit that there's not, or would you like to see a different system?
It's a great question, and I think those cases being explored in this way would be a really valuable thing to kind of bring into this educational format as well, because many hands makes light work, and if we're repeating and doing the same thing over and over, we're going to get the same results. So having more minds put to the challenges that we face in that space, and doing good engagement with First Nations communities and representation to make sure that any changes that we do make have the right outcome and the intended outcome that we're chasing, and because lots of people thinking about the same problems is going to generate a lot more ideas, and that we carry with us then the extra information that we need from these cases to be able to do better the next time around and prevent similar sorts of deaths. But to your question of deaths in custody and things. It's not something I've explored with the podcast so far, but would be very interested, especially because we do have that kind of touch point with healthcare in that setting too. It would be, really, I'm sure lots to learn in that space.
Has there been a case that you've seen really change practice? It's been very hopeful, very positive, very productive?
Yeah, well, I think working, I suppose my bias is in a real interest in the opioid stewardship sort of space and about opioid safety and things like that. So I think the investigations around certain opioid related deaths kind of as a group and kind of having spotted that trend that has led to system-wide changes of implementing things like your real-time prescription drug monitoring software, that I think that kind of system level change in response to what is, a public health issue is a really positive and meaningful outcome to come out of some of these coroners cases, but as well over even within the last decade, probably more within the last kind of 5 years, seeing the change in practice, in policy around opioids in particular, to mean that they are used more safely and more judiciously, and that more clinicians are aware of the dangers that they pose, that there's a very important piece of pain management, but we have that responsibility as well to be managing these medications in safe doses for the right patients, and that the disposal is managed and that people have access to things like take-home naloxone. Like, I think that tragic coroners cases are the impetus for so much of that high-level policy change, that it's very positive to see over the course of a relatively short amount of time.
I'm wondering if there's anything else you'd like to say that we haven't talked about.
Well, I'd encourage folks to have a listen to the podcast. So the Never Again podcast is available on Spotify and Apple Podcasts and some other podcasting platforms as well. So we do hope to be able to bring more coroners cases to more people in that format, where it's something that you can listen to while you're on your commute. Attached to the show notes, we do have some evaluation in there as well, because we're also conducting some research about this format of education in being an effective way to communicate clinical education for, in particular, building the body of knowledge around allied health clinicians and nursing staff.
Any early findings?
Well, we have had some feedback so far. So we've had about a dozen respondents, because we've had 1,400, 1,600 kind of listeners over the course, but then going in and clicking is the extra challenge. So of the results that we've had so far, it's been pretty positive feedback. So more than half of the folks who replied were listening while they were doing something else, doing something like commuting, exercising, cleaning, something a little bit more mundane, not needing all of your brain power to do. 80% of them said that they took something away from listening to it that would impact their practice, and 100% found that it was emotionally engaging, and that they would listen to more podcasts if they were available. So
congratulations, that's a very good response.
Yeah.
And thank you for your time here, Benita.
Pleasure, thank you so much.